fraternity of the dais. So today I'll be presenting my work on factors affecting medical students' interest in working in rural area in northern India, a qualitative inquiry. So at the outset, I want to thank the National Academy of Medical Science for bestowing me with this award and letting me an opportunity to present this paper in front of you. So, provision of adequate, affordable and accessible healthcare has been the mandate for many global health organizations, and including India, we are facing with that problem of provision of adequate health to all of us. And there is a shortage of doctors globally, and rural and remote areas are particularly focused when the shortage of doctors are concerned, which is hindering the progress towards the improving of healthcare of the people. Over 44% of the World Health Organization member states have fallen short of the standards of the doctors, which is at least one physician per 1,000 populations. So India is facing the situation where there is not only an inadequacy of health workforce, but also the inequity of health workforce. It has been placed in the lowest category of HRS, healthcare for indicators, and according to the rural health statistics, we have a shortfall of 11.6% medical officers, and when it comes to a specialist, it is around 81% of medical specialists at community health centers. And we have one physician for over 1,700 people against the norm of 1 per 1,000. And especially the poorer states like the northern states have lower density of healthcare workers, and especially in the rural area as compared to the southern states. And also we have seen the inequity in terms of male and female ratio, and also in terms of rural and urban. And this inequity we have seen in the COVID-19 crisis, when the physician played a very important role in managing COVID. Government of India has made several policies, and they have provided the financial and non-financial incentives in terms of better living conditions, educational opportunities, and even compulsorily rural field experience postings in different states. But some policies have led to significant change in the rural-urban distribution, but still we see from the recent data that we still have more doctors in the urban area as compared to the rural areas. So the objective of this study was to determine the discouraging and encouraging factors affecting medical students' interest towards working in rural areas of India. The study design was a qualitative study design, which was mainly the focus group discussions, and we took 6 government medical colleges of 3 states, that is Himachal Pradesh, Haryana and Punjab. Because they have almost equal area in size, health indicators were almost poor as compared to the southern states. And they have a predominantly rural population with a low population density and poor facilities for doctors. The study was granted ethical approval, and there was a funding support from Indian Council of Medical Research for undertaking this study. These were the 3 states which I am talking about, and these were the 6 medical colleges, government medical colleges we took during this. We have 636 medical students which we took, and these were all final year medical students and the interns who were selected because interns were near to complete the medical education and have to decide their postings in rural and urban areas. So for focus group discussion, we took 90 students from 6 FGD based on the approach that whenever we have the responses which comes almost similar, then we stop taking the sample size. There were ensurety about the homogeneity of the participants and the representativeness of the participants. And the 2 research assistants took notes, and we coded the transcripts, and the verbatim and thematic codes were generated and we were transcribed using a categorical aggression approach. So for the audience, the this categorical aggregation approach is a meta-ethnographic approach where there is a process of collecting the data from multiple sources and then presenting the data in a summary manner, like for example we do for the quantitative studies. And we also did a thematic analysis where all the transcripts which were there, their patterns were studied, their codes were generated, and they were assigned respective theme. Everything was done based on the correct guidelines by the qualitative studies. These were few questions asked during the focus group discussions. How many of you would like to serve in rural areas? What according to you are the motivational factors for working in rural setup? What would you say are the possible challenges faced while working in rural settings? What facilities have been provided by government to retain the doctors in rural areas? And what provisions should be made available by the government to encourage doctors to work in rural areas? So as far as descriptive statistics goes, so we have, these are the 6 FGDs, and we have almost a similar age group and gender. We have the final year and turn ratio almost similar, and the people were from rural background as well as from the urban background, so that we get both the views, and many of them have underwent pre-medical studies from the rural areas. These were the 5 themes, 2 themes from the discouraging factors like unchallenging professional environment and gap between financial rewards and social disadvantages, and the encouraging factors were the willingness to give back to the disadvantaged community, broader clinical exposure, and higher status and respect. These were some of the themes and the quotes by the doctors. In the interest of time, I will not read over the quotes, but some of the quotes were like, we can't cater to the diagnostic and curative needs of all the patients. There is no equipments, no medications, no staff at the primary health care center. So these are the unchallenging professional environment, and students cited the unavailability of cutting edge technologies, inadequate human resources support, fewer opportunity to travel abroad, and fewer research options as the barriers to work in rural areas. Second theme was gap between financial rewards and social disadvantages. So again, students felt that they would probably be isolated and left out in the remote and rural settings. Among the encouraging factors were the willingness to give back to the disadvantages community. Students had a desire to serve the poor and underprivileged communities who cannot afford the primary healthcare services. There was a broader clinical exposure, which they feel that they will get good clinical exposures while being in the rural areas, and the higher status and respect that a student perceive that they get more respect in the society if they practice in the rural community. We try to translate this to a Maslow's pyramid. Everybody knows about the Maslow's pyramid. So we try to translate this finding with the Maslow's pyramid. We have 5 need hierarchy of Maslow's pyramid, and most of the discouraging factors are in the bottom. And we did a systematic review of the various countries as a part of my dissertation, and there we find that most of the lower income countries fall in the lower range of the pyramid, that is psychological or physiological needs, and most of the high income country fall in the relatively upper pyramid. The strength of the studies are, we took the 3 large states of the country. The theme generated out of the present exploratory study are in support with the theme emanated from other studies, and we did strictly follow the correct guidelines for reporting qualitative outcomes. There were few limitations for the study as well, like study explained the opinion of medical students which may not be truly reflecting their decision to work in rural settings. There may not be a possible causal link between motivation and decision to work in rural settings. May have led to socially desirable responses when we interviewed them, and the improvement of the curriculum design of medical school based on the rural needs of equipments are beyond the scope of the study. The final conclusions were it was community-based medical education and a longer clinical apprenticeship in rural healthcare facilities are required. A medical curriculum review is required, and the need of the hour, providing equitable provision of healthcare services across rural and urban areas, preferential selection of recruiting students from rural area in medical studies, followed by their placement in rural areas should be preferred, and reorganizing the workforce through delegation of specific tasks to less specialized health workers, that is task shifting, should be promoted. There were few translatory values because we tried to do the from policy to practice, and the findings for this study were shared with the policymakers and medical educators of all these 3 states, and to make their concerted efforts towards facilitating medical student decision to working in rural areas, for improving workforce in rural setting, and strengthen the healthcare systems in achieving universal health coverage, and conducting research across different cross-cultural settings and also among the medical doctors practicing in rural areas. And finally, I would like to share with you that the results were also shared with the Parliamentary Committee of the Government of India, formed for the purpose of looking at the issue of poor retention of health workforce in rural India. This was published in this paper on PLOS ONE, and I did 5 papers out of this. Is part of my dissertation or research work which I did, and we developed 2 scales for India on discouraging medical students and for encouraging medical students, which is now highly practiced. Thank you very much.